Thank you all. I think it was a great panel, and I know it's been a very, very long day. So we've come to the end of the presentations, and I think we just wanted to save 10 minutes or so based on the interest of the group to have an opportunity for you all to ask questions or give comments on this theme of sustainability, how we navigate through the COVID-19 sort of response and resilience, and also think through school-based delivery approaches. So the floor is open to the room. If you have comments or questions, please raise your hand and we will get you a microphone. And this will be the last thing we do before dinner. So please do speak up, and would love to hear from all of you before we close.
Thank you very much. My name is Chizoba Wanodi from Johns Hopkins International Vaccine Access Center. Thank you to the presenters for an excellent presentation showing how HPV is rolled out in your country and the strategies you're using. My question has to do with integration. I know one of the speakers mentioned it. Could you please maybe elaborate more on opportunities for integrating HPV vaccination within other adolescent health programs in your country? Do you see that as a viable approach to enhance the current strategies that you have? And what would those adolescent health services be? Thank you very much.
All right, great. Thank you, Chizoba. Let's take a couple more questions. We've got one here and two in the middle and a fourth, and we can answer those.
Okay, thank you very much. I'm Mengistu from Ethiopia, HPV focal person. I would like to thank all the presenters for the insightful presentations. So I think my question first is for Christine. On your vaccination delivery strategy, you have mentioned that you will deliver the vaccination strategies in Kenya are school-based and health facility-based. I think there are a significant proportion of pastoral communities in Kenya because we do have in Ethiopia, so they are mobile, that they move, seasonally. So how do you manage girls living in the pastoral communities? The other thing is, maybe the question could go to all of you. As an African community, like for example, if you take Ethiopia, there are significant proportion of young girls who are attending school, but not regular school. No, they might attend the evening schools. They are really significant. If you take the case in Ethiopia. So in some of the cases in Ethiopia, we encourage vaccinators, to put a team during the evening period. Do you have that experience? Because we consider them as an out-of-school girls, but truly they are attending school, but not regularly there during the evening time. And my last question is with regards to the leftover vaccines, because the coverage is like, suboptimal coverage in most of the cases. So what are you doing once the vaccines are going down out of the hub? How do you manage the leftover vaccines? Are you vaccinating all walk-in girls in the health facility, or retrieve back to the next higher health facility? Thank you.
Thank you very much. My question is to Mr. Chipuso from Zambia. I hope I pronounced the name correctly. You did mention in your presentation that you have observed an increasing trend in dropouts from 1 and 2. I would like to know, what do you think is responsible for that? And what are you doing about it? Because you did not mention what, in your understanding, was responsible for that, and then what you are doing about it. Because you said the trend is increasing and it's worrisome, so we need to know what exactly is happening.
think we've got one more from over there, and then let's answer those and see where we are with time.
Thank you very much. My question is, with regard to the low coverage of HPV. Most of the presenters have mentioned that the school approach is good and they get some improvement while they are working on a school vaccination program. So my question is, why don't you use, more school-based vaccination program? What's the reason behind, not to leverage more on the school approach? Because in most of the presentation in Kenya, even in Zambia and almost all, you have mentioned that school is good to get adolescents for vaccination, but you didn't leverage it more to reach your coverage more in the high. Thank you.
Wonderful. Okay, let's have the panel address those questions, and then we'll see where we are. The first one is the opportunities for integration with adolescent health programs. Anyone want to start from that one?
Okay, so starting with the issue of integration, I think a number of things we've addressed the same matter of integration. Integration is really a key for us to progress and increase the numbers. And it's true, observation is correct that we need to look at those opportunities. So the first opportunity, that's how we keep on mentioning that the school health is a good approach. We just need to refine the approach and find better ways of doing it. So the first thing about the school health, what we've been doing so far in HPV, when we say school health, we've just been using the school as a pool where these targets are found. Not necessarily driving it together with the other already existing school health programs. Because like, for example, in Zambia, we have the BCG on school entry. We have tetanus toxoid for girls. So these have been going on, and even in nutritional programs in schools, they've been going on for years. But now in HPV, we use the school, not with these programs, but the school as a place where this target group is found. So now as a way forward in terms of integration is to find a way. Remember I mentioned earlier that since we are not getting good numbers with the 13 and 14-year-olds, because some of them is because they're changing grades and some they're dropping out. So we are, after the MAC HPV, we'll go back to the 9-year-olds. So the 9-year-olds together with BCG and other things we're using for nutrition, want to find a ways that we can integrate it too, so that we can improve the numbers. And then the out of school girls is true. Some of them are out of school because they're just absent for some reason. We'll still capture them when you do the outreaches, because outreaches just refers to that period of week we are doing the child health week. They are not in school then. Doesn't matter whether they are registered in school or not. They're not in school then we'll still catch them with the outreach service. And we still feel that the school health is quite important. Another thing we have also, we had as outstanding feature in school health in Zambia, that we still had a difference between government-run schools, which are public schools, and the private schools. So private schools emphasize on the consent, days and weeks before the week to the parents. And when you give a consent, there's an indication that something is not very correct. That's a perception people have in our communities. When you give them a paper to sign in advance to agree, they start wondering why. When they come for polio, no one gives a paper to sign. Then when they come for DPT, no one gives a paper to sign. Now, why this one? So that creates a problem, and there's no one to answer those questions. So we need to give the information to the teachers, the parents, even much more before we start planning for the campaigns. That one will help us to improve. Then maybe I can address the other issue of the dropout on HPV1 and HPV2 as well. So like I mentioned earlier, this factors mentioned the pupils changing schools because we were giving HPV 1 year apart. HPV1 this year, HPV2 the following child health week. So if a child is in grade 9 in HPV1, the following year they'll be in grade 10, they are changing schools because they write a qualifying exam in grade 9. So we won't find them in the same school. The same also in grade 7, they also change. So the dropout is as a result of them changing locations and some of them changing statuses. So we noted that kind of a challenge That's the reason why we decided to change our cohort now to 9-year-olds. We hope that group will be much more stable with social statuses and issues surrounding their movements.
In addition to what he has already highlighted, in terms of integration, especially for the young, there is a whole unit of Ministry of Health on school health promotion. And also the country is currently implementing NTDs, neglected tropical diseases, in schools. Obviously, integrating HPV with neglected tropical disease implementation will yield us results, because it's the same target group, the same people, and the same service providers doing the services. And as he highlighted, HPV is a concern. Mostly for other vaccine interventions, there is no consent. But when it comes to HPV, the demand for consent, especially in private school, is very high. But from our experience, there is no written consent from Ministry of Health. What we encourage is for private schools to conduct PTAs. Even if there will be consent, it will be from private schools. Because if private is demanding consent and ministry is given, how about the other child who is in public school living together with the one in private school? It brings confusion. So is there a mandate and obligation between them and the parents? They need to inform them earlier before the vaccination. So we provide information weeks before the intervention to both public and private, and we encourage them to inform parents to that regard. And the other question as to the balances of vaccines. Usually after HPV vaccination, balances are left at health facilities, especially the Gambia, because we have adequate cold chain system to store the vaccine. In as much as we are going for school strategy campaign, out of school girls are also reached at clinics and also using outreach services. So others in the community that will want their children to receive the vaccine will walk to the facility, or during outreach, health officers will use the opportunity to vaccinate within the population. So it's hardly for vaccines to be recalled to the national level. They are left at facility because there is enough capacity to keep them safe for the next round. Thank you.
Thank you all. I think I will not dwell so much on the first two because they have been well captured by my colleagues on that other side. So I will talk about vaccination strategy, why in what we are doing about the pastoral community in Kenya. What we have done is that our micro planning is a bottom-top approach, whereby the health facility and the community do mapping, and they do the actual micro planning. So one of the activities is to come up with our hard to reach populations and where they are and strategies to reach them. Again, we also work with the leaders of those pastoralist community so that we know their movement. And as we give other health services, we are adequately able to capture our girls to get vaccinated. Low coverage, why no school? Again, it has been said, and we also rely on the demonstration that was done, and that is what informed on the strategies. Thank you.
Thank you very much. And Dr. Clark, would you like to add some comments as well?
Yeah, so thank you. Let me say a big thank you to all the presenters and all those who asked questions. I would like to comment on some of the questions so as not to be repetitive. I think the first thing we need to recognize relative to the delivery strategy is to know that the strategy has to be informed or driven by empirical evidence that the country team generates. And so as much as we see school-based as a primary delivery strategy, we also need to recognize that if the enrollment rate of our target proportionate to those in school and out of school is suggestive that there are more girls out of school than in school, and our direction in terms of intervention is going to focus more towards reaching girls who are out of school, since that's where you have majority of your target being located. And so that's why I said in Liberia, our approach towards reaching our HPV target, which in this case are 9 years old girls, will be contingent upon county-specific strategy or county-specific context. Imagine you're in a rural environment, take a rural district where you don't have any school. School-based delivery strategy is not going to suffice because you don't have any school. So the primary delivery strategy has to be temporary site visitation, outreach, mobile services, or girls who parents will bring them to the health facility. So I don't want us to engulf the delivery strategy into a one-size-fits-all situation that because we're here in school-based, so school-based should be the number one primary. I think we should have an open mind for it to be country-specific, county-specific, district-specific, province-specific. What is critical is to allow the data to be run or drive that decision-making process. That's the first thing. The second comment I'd like to make with respect to integration, I think integration is good, but we got to look at integration from a balancing perspective. Is integration going to hurt you, or is integration going to promote you? And once that question is answered in the affirmative, then you can identify which adolescents' health intervention you can integrate with the HPV vaccination. We know that there has been effort from colleagues working in HIV and AIDS and relative to HIV and STDs prevention and control. We think that's a better platform because we are talking to our young sisters, our daughters, our nieces on the importance of HIV, the importance of the danger of STDs. And so leveraging on that platform to talk about the importance of HPV and why a 9 years old girl needs to be vaccinated with HPV, I think it's the best and smart move to make. And so in Liberia, we've decided to reach across the aisle. Our conversation is not just with the Ministry of Education, but we are also talking to colleagues in other control programs, for instance, the HIV program, to see how we can leverage on interventions that they are already carried out either at the school level or at the community level. So in the affirmative, I think integration is good, but before going into integration, we should be able to identify whether that integration is going to hurt us or if it's going to promote us. I'll stop you.
Thank you. Thank you so much, Dr. Clark. And those are some great thoughts. And I know we could probably continue talking for a long time, but it's been a very long day. I think we have one more comment to add, another colleague from Liberia. So please go ahead and then we will close.
Thank you, Adolphus, for your great presentation. As always, I just have this question. I know sometime in February of this year, there was COVID-19 vaccination introduced for school age children. I'm just here thinking, is the EPR program taking on leveraging on that COVID-19 intervention also for HPV vaccination? Thank you.
And thank you, Josh. So the answer is yes. As Liberia is among countries now that has begun the process of integrating COVID-19 vaccine into routine vaccination. So as we talk integration of COVID-19 vaccine into routine vaccination, we are also looking at means of medium through which we can further leverage upon to increase our HPV vaccination uptake. So we've had a couple of conversations with colleagues from the Ministry of Education to see how we can bring on board the HPV and that of COVID-19 vaccination for children 12 to 17 because we haven't introduced the pediatric dose yet. It is expected to be introduced October of this year, at which time we will be looking at 5 to 17 years for COVID-19 vaccines in school. And then we'll also be looking at the HPV for 9 years old group. But this is something that we are looking forward to seeing what lessons we can learn. And then that will guide our decision process to scale up. So the intent is to start with 3 counties in Liberia and then scale up to the remaining 12 counties. But just to answer you in the affirmative, yes.
Fantastic. Thank you so much. Thank you for the whole panel for excellent presentations and comments on all of these topics. I want to see if Deborah wants to add anything, and I will hand over the mic to Alex if he has any announcements and wants to close as well.
Thank you. I really enjoyed this presentation. It was full of the really practical realities we've faced in the last years. We have a very effective vaccine, but it is not proved always straightforward to deliver this at the levels that we would have hoped. And we've had also the COVID vaccination issues. So I want to congratulate the countries for thinking about the way they've moved forward, and to the more for a very excellent set of presentations. Thank you very much, and look forward to further discussions tomorrow. Over to you, Alex.
Okay, so I would like to thank everybody here. I think it was a long day, but we learned a lot. There was a lot of exchange, and this is only the beginning because we have another day tomorrow. Luckily, it's not so charged as this day. So I would like first to invite you. We have already 29 ideas for breakout groups, but I think it's good if you have, after this discussion, some suggestions for us. We will organize 3 breakout groups of 1 hour. So please give your opinion and we will take those into account as much as possible. So I would like to invite all of you at 8 o'clock for the dinner that is organized, where we can further exchange ideas, and the dinner will be served outside here. So have a good rest or some movement and see all of you at 8 o'clock. And I think we could end with a big round of applause for ourselves. Great job. Thank you.